So thank you very much, Steve, for inviting me. Just had a look at the names list, lots of familiar faces, lots of people who taught me everything I know. So I'm timing myself because this is a bit of a pet topic of mine and I do have a bit of a habit of waffling, so we'll try and keep to time. Um, and over the next sort of 40 minutes or so, I'm going to talk to you about what life is like for our patients post-critical care. So I'm going to start with what's really a mission statement, what I think that critical care is, and I hope that you would all agree. So the aim is not just to save life, but it's to create survivors with a quality of life they find acceptable. And that's a very individual thing. But until we know what life after critical care looks like, we won't know whether that is a quality of life what they will find acceptable. And very much tying in with the last talk, actually in the patients where it becomes obvious that that's not possible, that we're not going to either save their life or save their life so they have a quality of life they find acceptable, it's to try and facilitate a good death. And I'm sure that, you speak to a lot of people, especially elderly patients, they've thought a lot about death because they've lost friends and they've lost family members. And very few people, we would all like to die, comfortable in our own bed after a lovely meal and some nice wine, surrounded by those we love after a long and fulfilling life. Lots of people would probably not say that they wanted to die in intensive care with machines that go beep surrounding them, surrounded by strangers with tubes coming out of every orifice. So, but it is important, and that ties in very importantly, I think, with our last talk about palliative care. So let's start with why this is important, because I appreciate that I am talking to an audience of some intensivists, but also mainly anaesthetists, and why is this relevant to you? So the first thing is, any one of us listening to this talk could be admitted to intensive care, either as an elective or an emergency, or that could be someone that they love. And it's really important, or someone that we love. It's really important to know what survival might look like, what survivorship might look like. It's really important when we're thinking about our decision making. So which patients to admit to intensive care, either from the wards, when we get them to intensive care, whether we should limit any treatment, whether we should offer them full organ support. And I think particularly for this audience, decisions around high-risk surgery, whether that's the elective or the emergency setting, or surgery in high-risk patients where they're likely to go to intensive care after the operation. It's really important when we're thinking about information for the patients who are in intensive care about what their life might look like afterwards, what sort of problems they might face, where they might get help, what to expect, but also for their family members, for their carers. I've been running our post-ICU, our ECMO follow-up clinic since pretty much I started at Glenfield, and that is now 10 years ago. I've been a consultant at Glenfield for 10 years. Apologies if that makes some of you feel a bit old. And this is a really important part of my job, and I find it very rewarding, but also very humbling. And I think that I've learned an awful lot from my patients, and that has improved my sort of day-to-day clinical care in intensive care. So it's important to know again about the post-ICU problems, because we might be able to change things that we're doing in the acute settings that improve their longer term outcome. And finally, and if there's time at the end of the presentation, I'm going to talk to you about some of the things that I've learned from my patients at my follow-up clinic about how we can improve ICU, how we can humanise it. I can remember very clearly the first time that I went into intensive care as a medical student. And it was pretty terrifying. It's really loud, it's really clinical, the patients look really ill, there's lots of machines you don't understand and monitoring, lots of noise, lots of chaos, and it's pretty terrifying. And if we think it's quite terrifying for us as healthcare workers, how frightening must that be for our patients and for their loved ones who may have never been in a hospital before? So what can we do to try and make that a bit better? Let's start with some statistics. So quite a lot of people get admitted to ICU per year in the UK. It's about 200,000 adults a year. It's quite a big cohort. And actually, our critical care capacity and our critical care survival is changing. So sort of over the 10 years pre-COVID, we increased our England our England adult critical care beds from about just over 3,500 up to over 4,100. That obviously went up a lot in COVID. It's probably higher still, although not to the level that we were at in COVID. Although I'm sure a bit like Leicester, everywhere's having problem with kind of recruitment of staff to critical care because we lost a lot of particularly nursing and AHP staff sort of post-pandemic or during the pandemic. And our survival is improving. So back in 2010, 2011, and this is data from ICNARC, about 76%, about 3/4 of people survived their ICU stay. And then just before the pandemic, that's now up to about 4 out of 5. So about 80% of people survive critical care. So for the majority of people who are admitted to critical care, they do survive. So actually what their life looks like post-survival is a really important question to ask. And just like we started talking about in the last talk, we are seeing a change in demographics. So we are definitely admitting people to intensive care who are older, who are more multi-morbid. What comes with that is more frailty. And definitely, even over the last 10 years, we are doing higher risk surgery on older patients. So we have more patients who are admitted, more survivors, and an older, more multi-morbid population that we are looking after. So what does the research tell us? Well, the vast majority of critical care research focuses on short-term survival, so 28-day, 30-day survival, or even what they term, slightly oddly, longer-term survival, which is often 90 days. If you talk to a patient and you say, yes, you are, you've got an 80% chance of surviving intensive care, actually, is an important question to them, will I be alive at 30 days? Because that's what the majority of the ICU research tells us. Probably not for the majority of people. They want to know, well, if I get out of ICU, will I sort of face repeated readmissions to hospital? Will I have to be readmitted? Will I get back to normal? That's the most important question that people want to know. What will be the knock-on effect? What will be the knock-on effect on my family, on the stuff that I like doing, on my work? What about my finances? Will I be able to go home? Will I be able to go home? Will I be able to go back to my previous job? Will I go back to the activities that I was doing before critical care? And I suppose all of that can be sort of put together with, what will my quality of life be like? What does ICU survivorship look like? What will I be like at 6 months, at 12 months, at 5 years, at 10 years? And really, we have far less data to inform that. And part of that is hampered by the fact that if you're looking at a simple metric of survival, it's binary, yes or no, live or dead. It's easy to measure, it's easy to record. When we're looking at things like quality of life, that's much more subjective. We use different tools, so we have different ways of measuring things will give you different answers. But these are really important questions. This is what we really want to know. This is what our patients will want to know. So I'm going to try and answer some of those questions by what's in the literature. Let's have a first look about whether people need to be readmitted to hospital, because quite frankly, we didn't really know before we started following these patients up what happened to them after they went from critical care. We're like, yeah, they survived, brilliant, we've done our job, tick. But what happens next? So this was a big systematic review, meta-analysis that was published in Anaesthesia just at the end of 2021. And it's a big cohort. They looked at over 3.8 million patients, mainly from North America, next biggest group from Europe, a few studies from sort of around the rest of the world. And this is quite terrifying. Again, the pooled estimates for hospital readmissions, this is readmission to an acute care setting, post-critical illness. It's 1 in 3 patients in the first 90 days, the first 3 months, and it's over half within that first year. And they also had a look in this study at the risk factors for rehospitalisation, and unsurprisingly, it's that older, frailer, more comorbid population that are higher risk of readmission. We probably could have predicted that. but also what happened when they were intensive care in the first place. So a longer length of delirium, and I'll talk a lot about delirium during this talk because it's very relevant to PICS, to post-intensive care syndrome, and the patients who were on the ventilator for longer. So minimising delirium, getting them off the ventilator quicker may reduce readmission rates. And the other big group, the other big risk factor was patients who got infection post their hospital discharge. So in answer to the question, will I need to be readmitted? Actually, the answer is, well, probably yes. You've got a 50-50 chance of needing to come back into hospital within that first year of discharge after intensive care. What about quality of life? And this is what I'm going to concentrate on for most of the rest of the presentation. And we're going to go over what intensive care, the post-intensive care syndrome is. How common is it? Can we do anything about it? Can we modify it? Can we improve it? I'm going to touch on what happens to the families, what happens to the people who are sitting by the bed, not in the bed. And then finally, if I've got time, I'll talk a little bit about what I can learn from our patients. And I don't know about you, but I found this is kind of taken from the first wave of COVID. This is sort of sweet, but maybe a little bit naff, that whole kind of, not all superheroes wear capes, some wear PPE. But everyone has a dirty secret. And I think up until recently for critical care, that was the sort of state that we left our patients, that we left our survivors in longer term. And the reason it was a dirty secret is because we just didn't look at it, we didn't measure it, and we didn't know it was a problem until we started following these patients up. So, post-intensive care syndrome. So this is the definition: define or die, new or worsening impairment in physical, cognitive or mental health arising after critical illness that persists beyond discharge from the acute care setting. And this was a term that was coined at a Society of Critical Care conference back in 2010. And the idea was that by giving, everyone loves a syndrome, don't they? The idea is by giving a name to all the myriad of problems that patients face post-survival, that we could raise awareness of the problem, that we could improve screening and detection and hopefully offer support to improve recovery or to maximise recovery, and that we could facilitate further research in this area, which I've said there is a bit of a paucity of data for. And divided into three main groups. So the physical groups, lots of physical problems, but probably the three big ones are muscle weakness, or ICU-acquired weakness, fatigue and exercise intolerance. And fatigue isn't normal tiredness. We all get tired. Tiredness is a part of life, isn't it? But what fatigue is it's defined as an overwhelming, sustained, subjective, again, so difficult to measure because it's subjective, sense of physical, emotional, and or cognitive exhaustion that's not related to recent physical exertion, that interferes with people's activities of daily living. And then finally, sort of shortness of breath. When we're looking at the cognitive domains, we see problems in all sorts of different cognitive functions. So memory, executive function, language, attention, visuospatial abilities, poor concentration, processing problems. And then when we're thinking about mental health, about psychological ill effects of being in intensive care, the three big ones are symptoms of anxiety and depression and even post-traumatic stress. So how common are they? Well, again, this is difficult because prevalence massively varies depending on who you're looking at and what you're using to find out the sort of presence of this. And we don't have any universal screening tools. So you ask a slightly different set of questions, you get slightly different set of answers. But all of these sort of prevalence are taken from systematic reviews or meta-analyses. And as you can see, it's pretty common. We're talking about muscle weakness in almost half of our patients, fatigue, which we said is not only one of the most common symptoms, so over half of the patients, but also might be the most prevalent because there are some studies looking at 5 and 10 years post-critical care, and fatigue still features prominently. So that might be pretty pervasive. And then shortness of breath, this is hampered a little bit because a lot of this research is done on the ARDS population, but it's somewhere between sort of a quarter and a third of patients feel breathless in those first few months post-critical care. I'm going to talk a little bit about some of the research around the cognitive problems, but this is a real problem. And we're talking about between a quarter and a third of patients have longer term cognitive problems post critical care. ICU is bad for your brain. That's basically the take home message there. And then the sort of psychological problems, and again, these are taken from sort of big systematic reviews, but they're pretty prevalent as well. Anxiety in about over a third, clinically significant depression in over a quarter, and rates of post-traumatic stress disorder of over 1 in 5. And to give you an idea, that's about the same level as we see in returning combat veterans from Iraq and Afghanistan. So this is, again, a real problem. One of the questions that's always asked is, well, how many of these things are new problems and how many of these things were pre-existing? Because, the majority of people who come to intensive care come as an emergency. So we don't have baseline data on those patients. It's a bit easier to do on the elective surgical patients. This was a big Dutch study, so it was conducted 2016 to 2019, so just over 2,300 patients. And what they wanted to ask was, what's the prevalence of new PICS symptoms after intensive care? So trying to discount the ones that were already present before the patient was admitted to intensive care. And they got the patients or their loved ones, their proxies, to rate their health status both before and then a year after ICU admission. And for the elective surgical patients, that was a questionnaire that was sent out to the patients before they were admitted for their surgery. And for the others, that was a bit of a retrospective analysis with obviously the problems that you've got in looking back on how you were before you got poorly. Looked at lots of things, so frailty, fatigue, new physical problems, new psychological problems, cognitive impairment, and then some quality of life metrics. And the sort of scores on the doors, the results are looking at specifically new problems a year post-intensive care. They found that it was pretty prevalent. So 58% of medical patients, 2/3 of urgent surgical patients, and 43% of the elective surgical patients had new PICS problems a year post-ICU. Back to the brain and ICU being bad to the brain, this study showed that there was a significant decline in cognitive function, and that was seen in all 3 of those patient groups. And again, unsurprisingly, how you were before intensive care massively sort of was a big factor here that was associated with increasing problems post-intensive care. And again, relevant for the fact that we're admitting older, more multi-morbid, more frail patients. Let's talk a bit about the brain, because this is the thing I have to say as someone who may be admitted to intensive care in the future is something that worries me most. This is the brain ICU study. This was published in the New England Journal of Medicine back in 2013. And again, it's for ICU, it's a big study. They looked at 821 patients, and this was a sick cohort. So these were patients with either shock or severe respiratory failure. So the vast majority were on ventilators and the vast majority received vasopressors. And what they did is they followed them up at 3 months and 12 months. They had some trained psychologists to do that. And they did a battery of sort of different neurocognitive testing, and they did things like a trail making test. And they followed them up at 3 months, followed them up at 12 months. And then they compared that to what would be population means, so age and sex matched population means for cognitive function. And they found that at 3 months, 40% had global cognition scores that were more than 1.5 standard deviations below the population mean. And that was akin to moderate traumatic brain injury. And 1 in 4 had scores that were 2 standard deviations below the population mean, which they described as a cognitive impact of mild Alzheimer's. When they followed them up for 12 months, it was still pretty pervasive. So 1 in 3 had moderate, what you classify as moderate traumatic brain injury, and 1 in 4 still had that mild Alzheimer's. And they looked specifically at younger patients, so patients under 50, with no past medical history. And they followed them up at 12 months. 1/3 of them had cognitive scores akin to moderate traumatic brain injury, and 1 in 5, so 20%, had those scores sort of akin to mild Alzheimer's. And again, they found that an increased duration of delirium led to worse global cognition and executive function. And they found that delirium was really common, 3/4 of those patients. It's important to note that actually they excluded patients who had pre-existing problems with cognition, pre-existing dementia. So that's pretty terrifying. ICU is bad for your brain. That's a message to take home. So we know it's a problem. We probably know it's an increasing problem because we're admitting more patients and we're admitting more patients who are at risk. Can we do anything about it? Well, yes and no. There's stuff that we can't change. We can't change the fact that our patients have pre-existing disease, their age, their levels of frailty. We probably can't necessarily change how severe their disease is, and we may not be able to change how immobile in bed they're going to be, apart from maybe not admitting these patients to critical care. But there are some things that we can try and modify, because we know that these are all risk factors for PICS symptoms in the different domains. So in the physical domain, we know that the longer you're on the ventilator, the worse. It may be worse if you are paralysed. It may be worse if you have steroids, but interestingly, there is maybe some data around the fact that if you are given steroids, some of the psychological problems are better, which is interesting. And we know that delirium is a problem. And you'll see delirium comes up in all three of these aspects. For the cognitive things, we know that delirium and pain influence that. We know that hypoxia and having sort of swings of blood sugar, and we know that longer sedation and particular types of sedation might be more of a problem. And that's exactly the same for the longer term mental health problems. So there are some things that we can target. And I'm sure that you've all seen there are many bundles. It's a bit like a syndrome, is it? We love a bundle in intensive care. And this is called the ICU Liberation Bundle, which is A to H or A to F. And this is looking at all these different aspects in every patient every day. And that's initially looking at assessing pain, preventing it, managing it. B is for spontaneous breathing trials, and also sedation holds goes hand in hand with that. C is the choice of analgesia and sedation that we use. We know that certain types of sedation, such as benzodiazepines, are associated with more delirium and therefore might increase the risk of longer term problems. We know that delirium is an issue, so we need to make sure we're looking for it. We need to make sure we're trying to minimise it as much as possible. We're managing it. We want to try and rehab these guys early. We want to try and get mobility and exercise to minimise ICU-acquired weakness, maintain that muscle strength, that muscle mass as much as possible. We know that improving sort of family engagement and empowerment, and that's about warning them what to expect, how they can help, where they can get help, good communication, and having some written handout materials, because people don't take in everything that's said to them verbally. So it's good to have some written things for them to take home. And then to the right of the screen is all the stuff that is important once patients have got home. So support, managing, sort of assessing, picking up those significant psychiatric symptoms and managing them. Best advice on nutrition, on sleep, and then that big group, that rehab, the impact of the therapies on ongoing care, post-critical care, both when they're still in the hospital and also when they go home. Does this make any difference? Do we have any evidence that actually things like this bundle can modify things, can improve things? Well, yes, we do. So there have been quite a lot of studies now looking at different hospitals that have implemented these bundles. And this was a huge sort of look at over 15,000 adults. This is a North American study. This was published in January 2019. And they looked at 68 different intensive care units in the US, so more than 15,000 patients. And they found that if you sort of ticked all parts of these bundles, you're trying to do everything, you're trying to look at the pain, choose your sedation carefully, awake and breathing trials, sedation holds, managing delirium, early mobilisation. And they found that if with complete bundle adherence, they actually found a significantly less hospital death within the first week, less patients who were in prolonged coma, less delirium, and that's quite key, less physical restraint use. Obviously, that's not something we use in the UK. We just chemically kibosh them instead. Less ICU readmission. That goes back to that readmission rates. And then finally, significantly less patients who were discharged to somewhere other than their own home. So more patients went home to their own home when this bundle was implemented. And they found a sort of significant sort of dose response relationship between doing more of these bits of the bundle and better outcomes. What about really simple stuff like ICU diaries? So ICU diaries, I don't know whether you do this routinely in Nottingham. It's something we've been doing for some years. And, you know, it might be seen as a bit flowery, a bit of a sort of nice thing to do, but actually does it improve outcomes? And the answer is yes. When you give patients a diary, or you keep a diary when patients are in intensive care, and this can be filled out by not just the nursing staff, but all members of the ICU team, that just fills in some of those gaps. So when they weren't aware of what was happening, what was actually happening, what happened to them when they're in intensive care. And this is a meta-analysis that was published quite recently, 2022, and that looked at 7 different studies where they were specifically comparing patients who received a diary to patients who didn't. And they found a significantly lower rates of post-traumatic stress disorder in these patients. And they found numerically lower, although it didn't reach statistically significance, lower rates of depression and anxiety. So this isn't just a fluffy, nice thing to do. This is a thing that can really improve outcomes. And I don't know if any of you have read this. Michael Rosen's a bit of a hero of mine. He's a children's author, and he was very poorly with COVID and had a long time in intensive care and has made a really good recovery. And he talks about his COVID ICU stay, and he uses extracts from his diary. And I suggest that you read it because it really gives the importance of the diary to him. And this is something that my patients coming back to follow up tell me, over and over again, how valuable they find that, and they go back and they look at it over some time. What about the person sitting by the bed? What about problems in the family members? And this is mainly sort of centered around the psychological aspects. And this again is a real problem, but like that cartoon there, it is a can of worms. I ask the family member at my follow-up clinic, how they are, but obviously don't open that can of worms unless you've got some help that you can offer them. So we know that there is a burden of psychological problems in the family members. And what I would generally say to the family members when people come to clinic is I say this, things like talking therapy, this is available to anyone in the family that might need it, because sometimes it's not the patient who has the major problems after critical care, it is the family members. I want to talk a little bit about what I've learned. So I've been running, like I said, the ECMO follow-up clinic since 2015. And we analysed the first 200 patients. And this is, again, pre-COVID, but good database. And what I do in the clinic is we invite them back. In fact, I try and see them in, sort of what our communication room, in one of our communication rooms in the intensive care unit, or the bad news room, you might call it. And I do that for a particular reason, that often that is the room that we've taken their loved ones in when they've been very unwell on the unit, to sort of, either update them or potentially give them bad news. And I think that it gives closure to the families, to take them back to that room with their loved one who has survived, to sort of try and kind of close that loop. And what we do is we do some basic tests. We do some spirometry, we do chest x-ray. I send them some questionnaires. We use the PTSS-14, which specifically looks at post-traumatic stress symptoms. Obviously, I'm not a psychologist, can't diagnose them with post-traumatic stress disorder, but it looks at symptoms for patients who've been in intensive care. We do the EQ5D, which is quality of life, and we also use something called the HADS, which is the Hospital Anxiety and Depression Scoring System, and they're self-reported sort of tick boxes. I get them to fill them out before clinic. The pie chart on the left just gives you a bit of a breakdown of the sort of different problems, as you can imagine, of patients who would need ECMO. So majority of flu, quite a lot of pneumonia, about 1 in 10 are asthma, and then there's various other things. And what I found with those first 200 patients is that quite a lot of them say they have at least some problems with walking about, so half of them. About a quarter of them have at least some problems with self-care, so ADLs. This is at 6 months post ECMO discharge, and moderate to severe pain or discomfort in a significant proportion as well. And again, looking at the HADS questionnaires and the PTSS-14, it's relatively similar to that big sort of meta-analysis that I shared with you earlier. About a quarter are depressed, almost half have reasonable anxiety symptoms, and about 30% have post-traumatic stress symptoms. One of the most important metrics, I think, is actually, are you back at work? And this is the thing I think that is I'm most proud of, because over half of my patients at 6 months post surviving ECMO are back at work. One of the questionnaires asks, what do you remember from your time in ICU? And this just to give you an idea of how terrifying it must be for our patients. So 17% can remember being in severe pain. Almost half can remember they were struggling to breathe or felt like they were suffocating. 2/3 said that they had severe anxiety or panic, and 2/3 had nightmares. So this is thinking about how scary the ICU is to them. I'm going to leave time for questions at the end, but I just wanted to really quickly talk about some of the things that I've learned from my patients at follow-up. And like I say, I find it rewarding, but very humbling. But it's changed how I look after patients acutely. And it's certainly made me much more patient with my level 2 patients who are delirious. You know, and I'm sure the nurses hate it when they've got a patient who's all over the place, might be a level 2, might not be on a ventilator, and is trying to pull out lines and is trying to get out of bed and is, you know, very suspicious. But when you talk to them about the delirium and the hallucinations that they have experienced, what your brain makes up to fill in the gaps turns out is way more terrifying than actually what's happened. And that's one of the reasons why sedation holds are so important, because you can maybe try and input some actually what is happening rather than what the brain is making up to fill in the gaps. I've had mothers tell me that their hallucinations were that their children were being harmed in front of them. I've had a lot of people tell me they thought that they were dead. Interestingly, there are some quite pervasive hallucinations. A lot of people think that they're on transport. They think that they're on boats or that they're on trains. And I suspect that's something to do with our pressure relieving mattresses feeling a bit like, you know, kind of the rippling of being on water. Like we said, a lot of patients say they can remember pain and they can remember feeling breathless. And there are specific things that we do in intensive care that aren't necessary evils, such as suctioning. You know, any patient who's on a mechanical ventilator would need suctioning. When you talk to the patients about what that actually feels like, you know, our tracheas are not designed to have even soft plastic tubes go down them. So they say, you know, the tubes go down and it burns. And often, actually, if you bronch a patient who's been on a ventilator for a long time and you'll look at the carina, there are lots of tiny ulcers there. And that's from repeated suctioning, which is important. You need to clear those secretions. The other thing that the patients say about suctioning is, especially if they have respiratory failure or they feel like they're struggling to breathe, you put that suction tube down, that hurts because it scratches. And then they feel like all of the air is sucked out of their lungs, because that's essentially what we're doing. We're using suction to suck air out of their lungs. And that feels really scary because they feel like they can't breathe anyway. They can't cough up the stuff that's on their lungs. And then we suck all the air out of their lungs. So it's just having an awareness of that and explaining to the patients what you're going to do, when you're going to do it, even if they're really heavily sedated. You know, I've got to pass this tube down into your lungs. It helps clear your lungs. It might be uncomfortable. It might feel like you're taking your breath away for a second, but it will then get better again. Sleep is a major problem. I personally think that the lack of normal sleep on intensive care is a huge driver of delirium. And there have been few studies on sleep in ICU. There has been one done in Australia where they found that the average length of time people slept for was 20 minutes. And, you know, we all know what sleep deprivation is like, either from clinical work or from having small children at home. And we know how badly we sort of, you know, how terrible that can make us feel. But there are things that we can do to improve sleep in our patients. We can make it less light at night. We can make it less noisy. We can try and minimize the things that we do to try and give our patients that sleep-wake cycle and try and give them as restful night as possible. A lot of patients talk to me about how awful it is not being able to talk and not being able to communicate, and how they really, when they got their voice back, either because we got a speaking valve on their trachea or because they got extubated, how important that was that they then could communicate. Thirst is a big thing. If you go into your intensive care unit now and you look at the number of patients who are hypernatremic, that is quite a high proportion of them. And that's sometimes we're using that as therapy, for example, in our neurocritical care patients. It's because we have sodium in a lot of the drugs that we give. And it's also because if you're having an acute kidney injury that's recovering, your kidneys, you know, pee out water first, and then start to process the sodium. So you get your diuretic property back before you get your natriuretic property back. As soon as your sodium is high, though, your hypothalamus is screaming at you, you are thirsty, you need to drink. And then, of course, we don't allow our patients to drink because they've got tubes or trackies in. And we give them those little mouth swabs for their lips, which is, if you're feeling incredibly thirsty because your sodium is high, that must feel like torture. A lot of patients think that they're paralysed, and that's probably, we use quite little paralysis, although there are some patients who are still paralysed in intensive care, but also that's the ICU acquired weakness. They literally can't move their limbs. So it's important to, again, sort of expect that and say to the patients, everything will feel very weak because you've been so poorly. That will come back. It just takes time. And that final one, everyone around me was dying. This was particularly fed back during COVID. And actually, the answer was they probably were. But the cardiac arrest in the bed next to the patient who's awake can have a profound effect on them because they're thinking, am I next? And then very quickly, some of the post-ICU stuff, things to ask about, things to warn people about, musculoskeletal problems going forward, patches of numbness, weakness. Most patients have neuralgia paresthetica post-ICU, whether they were prone or not. Medications, we often start loads of drugs in intensive care and they get discharged to the ward on some of those drugs, and they often get discharged home on those drugs because people are like, oh, well, that was started by the clever people in intensive care, it must be very important, and actually was needed for the acute problems in intensive care. Quite often at 6 months, I find patients are still on clonidine, are still on, the antihypertensives that they've been started in intensive care when actually they've now got completely normal blood pressure. We need to ask about things like swallowing. ICU can really affect your taste buds, back when they've managed to put their weight back on again. Hair loss is a big thing. Might sound like quite a minor thing. Actually, that can be quite important to certain patients. When you're very poorly, your body puts no energy into hair, skin, and nails. Skin turns over really quickly, so often they peel their skin off while they're still poorly, and then that comes back again. Nails, they often get ridges on their nails when they've been really unwell or they fall out. But hair grows in 3-month cycles. So often people experience significant hair loss 3 months post-intensive care. So that's just at the stage where physically and psychologically they may be starting to improve. And they're like, oh, great, and now I'm going bald. So just warn them. It will come back. It's that usually the hair follicles are dormant rather than dead. So it comes back, but they just need to know that. It's a big thing about survivor guilt. And often patients who've survived critical care are reticent to talk about if they're feeling, psychologically unwell or their physical problems, because everyone around them's like, oh, we were told you were going to die, and then you've done so well and you're doing really well, and they kind of feel guilty not only about surviving but about sort of complaining about what might seem to be minor things. So it's important to say to them, it's okay to be cross about what happened. It's okay to almost mourn the person you were before you were poorly. It's okay to be angry, but don't let that affect your recovery, because you need to maximize your recovery. A lot of patients are quite scared about going out. They don't want to get ill again, particularly if they've had an infectious disease that's brought them into intensive care. And I've talked a bit about the diaries already and how important they are. So I think that's me done waffling.